Well, thanks, Carrie, and welcome everybody. So, as Carrie mentioned, I am filling in for my colleague Debbie. She also works within the CardioPrevent program as well. So, as health coaches within the CardioPrevent program, and what that is it's a prevention program for individuals at risk for heart disease. So, we look at behavior modification, lifestyle changes, things that we can do to lower our risk for developing heart disease. So, we consider ourselves risk factor experts. So, today we're going to go through that a little bit more. So first, and the objective of today is really we have to know, understand, and act. These are our three main words that we're looking at. We're looking at how we can prevent our risk or manage our condition with cardiovascular disease. So number one, we have to be aware of what the risk factors are. If we don't know what they are, how can we make changes? How do we know what that means? Secondly, we have to personalize that risk for us. So just knowing what they are, we have to understand what that means for us. So finding where we fall within these risk factor categories, what that means, how can I make those changes, where do I fit within those targets? And that all leads to actions which let us lower our risk or manage our condition, prevent a reoccurrence if we already have cardiovascular disease, so we're improving our cardiovascular health overall. Okay, so I've already mentioned it, Carrie's mentioned it, we keep talking about risk factors. Probably basic information, but what risk factors are behaviors or conditions that lead to an increased risk of disease. So with cardiovascular disease, we have modifiable and non-modifiable risk factors that we're going to talk about today, meaning we can change and some we cannot change. So we'll start with the ones that we cannot change. So our non-modifiable risk factors shouldn't be much of a surprise to all of you, but we have our age, our sex, ethnicity, and our family history. Okay, so with age, as we get older, our body doesn't quite work as efficiently as it once did. Right? So things get a little tougher, a little slower, a little weaker overall, right? So if we think of a new car versus an old car, things aren't quite as efficiently. We have to care for it differently as well. Same with our bodies. So as we get older, our risk for cardiovascular disease increases because of other risk factors, so we just have to treat that a little bit differently. With age, the one thing that's different between men and women, so men typically we see our risk climbing for cardiovascular disease at an earlier time point. So around the age of 55 is where we start to see that increased risk for men, where women we see it about 7 to 10 years later around the mark of 65. Okay? Which I'm going to jump into our sex. So being born male or female has different measures when it talks about cardiovascular disease. So for men, men are more likely to have a heart attack than women. But women, our risk will increase dramatically after menopause. So we have these hormonal protective effect that will help us kind of keep our risk nice and low and managed. But 7 to 10 years later, so around the age of 65, we have a dramatic increase in our risk. So we might be trending nice and low, but below the men. But as soon as we hit age 65, if we're matched for risk factors with men, we are at the same risk level. Okay, so it's a very steep incline for women once we hit menopause. With sex and women, there's also a few other things. So we have a lot of hormonal conditions. So events at pregnancy can determine our cardiovascular risk. So if you experienced gestational diabetes, preeclampsia, gestational hypertension, premature birth, those sorts of incidents can put you at a higher risk for developing cardiovascular disease later on in life. So it's seen like a stress test on our body. So later on that we might be more likely to develop those sorts of conditions later on. And then we've already talked about the hormonal condition of menopause. Also things like polycystic ovary disease and things like that actually play a role in our hormones, can affect our cholesterol levels and affect our risk for cardiovascular disease as well. So our family history and ethnicity, they kind of, both of these are based on our genetics, as well as our behavior and learned experience and habits. Okay, so with ethnicity, there is an increased risk for First Nations, African, and Asian descent, and this is based on genetic linkages, as well as some of the cultural habits and practices that come along with it that put us at an increased risk for diabetes and blood pressure. Same with our family history. We do have that genetic component, so if mom, dad, brothers, sisters are first-degree relatives, and we talk about that premature cardiovascular event, so men before the age of 55 or women before the age of 65. If we've had a cardiovascular event or someone in your family has at those age, that means that you have a positive family history for heart disease. which can double your risk of developing heart disease. Part of it is based on the genetics, part of it is based on those habits and learned behaviors that you've experienced throughout your life and started throughout. So one thing with cardiovascular disease, we do know that our risk increases much later in our mid-life span, but the risk for cardiovascular disease starts early in our second decade of life. So those risk factors start forming when we're quite young, so we're still living under the care of our family and doing the things as they do. Okay? So moving on to our modifiable risk factors. So the good news with cardiovascular disease is we can prevent up to 80% of it. Okay, and that's through these modifiable risk factors. So on the screen are all of our modifiable risk factors. So we have high blood pressure, high cholesterol, diabetes, poor or inadequate nutrition, psychosocial factors like stress, anxiety, depression, smoking, overweight or obesity, and physical inactivity. So all of these are independent risk factors for heart disease. Today, just based on timing, and I think because we only have 30 minutes this morning, we are just going to focus on more of these clinical risk factors. So we're going to dive into each one of these a little bit more. These are the more clinical risk factors, where the other risk factors are a bit more behavioral and can impact these ones, but they are also standalone risk factors. So I think during the talk at 2 o'clock today, I think with Marion and my colleague Nadine, they're going to launch into a little bit more of the behavioral risk factors. So if you're around there, you can learn about those as well. Okay, so I feel like I'm preaching to the choir here a little bit, but we're going to go through. We have to know, understand, and act. So what blood pressure is the force of the circulating blood in our system against our arteries. Okay, so when our heart pumps, a wave of blood is put out through our arteries, which is filling our body with nutrients and getting all the delivered and all the oxygenated blood delivered to the organs and places that we need it. But, sorry. When our blood pressure, when we have an increased demand for the amount of blood, or we have narrowed arteries, our blood pressure increases. So the amount of blood going through a smaller zone will cause an increased pressure on those arteries. This, over a long period of time, can cause damage. Okay, so when we're looking at regular blood pressure, day to day, throughout your day, your blood pressure is going to increase based on the demand you're putting it at. So right now, most of you are all at rest, sitting here nice and calm. Typically, we'd expect to see a lower blood pressure. I'm up here with all these eyes looking at me. We'd expect that my blood pressure is going to be a bit higher, okay? If we're out walking, if we're exercising, that sort of thing, your blood pressure is going to be increasing, okay? So when there's an increased demand to your body, you're going to have a higher blood pressure. Temporarily, that's okay. Where we're concerned is when it's a longer time frame, okay? So a normal blood pressure, or blood pressure is recorded in two numbers. Let's start there. So the top numbers are systolic. So that's the force of the blood, our pressure when our heart is beating. So when our heart's at work and it's pushing the blood out. So that's what that top number represents. Diastolic is our bottom, when our heart is at rest, between beats, filling back up with the blood before its next beat to pump out. Okay, so optimally, we'd like our blood pressure for majority of population to be below 120/80. You can see here that we have different ranges where we get to be elevated. We have higher risk. One high blood pressure reading does not equal hypertension. So we'll see your doctor. It would be taken over many different time frames, different time points, and sequence of readings. Over 135/85 would be considered high. Okay? So why does that matter when we're talking about our heart? Is that high blood pressure over a long period of time is causing excess damage on our arteries. So it's causing a lot more force, it's causing a lot more strain, it's reducing the elasticity, it's causing damage to that area. When we have damage to that area, it acts as like little rough spots so that our fatty deposits, which we'll talk about cholesterol later, but those sorts of things can actually start to stick and cause damage and to adhere to those walls. Okay, so when they start adhering to those walls, that's forming that plaque and those fat deposits, which narrows the space that the blood can travel through, narrowing the arteries, so reducing the amount of blood that can go through there. So if you're exercising or there's an increased demand where your blood pressure or you require more blood, it's still pumping out the same amount of blood, but it's trying to go through the smaller point, right? So now your blood pressure is going to be increased. So that over time is how it can actually start to damage your arteries, cause weakening to those areas. Okay. Right, so if you have high blood pressure, most of the times you won't have any symptoms. So it's known as the silent killer because it's something that we don't typically feel. So unless there's been damage already, you might experience some sort of headaches or different symptoms, but for the most part, there's no symptoms. So the one way to manage your blood pressure is to check it. Okay, so we're also going to talk into a few other strategies of how we can keep our blood pressure nice and low. So number one is to reduce our salt or sodium intake. So here you see it says below 2,400 milligrams. If you have hypertension, pre-hypertension, if it's already elevated, we actually suggest to be below 2,000 milligrams a day. I know that no one's counting little grains of salt that you're having, but that's about 6 teaspoons, 600 milligrams in a meal. So just knowing that the number's a little bit more strict whenever you do already have high blood pressure or leading that way. Move more, sit less. So physical activity, we've talked about that. We've got the track today, so you're out there, feel free to walk around. So again, the target for exercise, 150 minutes minimum a week of moderate intensity exercise is enough to start managing our risk factors, okay? So that's about 30 minutes a day, 5 days a week. If you can go for a brisk walk, get your heart rate elevated, the more you're working out your heart, which is a muscle, it's going to pump more efficiently. It's going to be able to push more blood through without less force, without less work, okay? So that's one way of managing that. Maintaining a healthy weight, so a lot of this, many different factors within our weight, but physical activity, looking at our nutrition, the types of foods we're eating, the amounts of foods we're eating can actually play a large role in that. Even a modest decrease of 5% of your body weight can cause a change in your blood pressure, a significant change. Increase fruits and vegetables. So these, again, as you saw in that first place, a lot of these are those risk factors for heart disease, but they do play a role within some of these other risk factors. So increasing fruits and vegetables, trying to hit those 5 to 7 servings a day, nice nutrients, high fiber foods, reducing alcohol intake. So for women, we've got majority of women here, recommendations 1 to 2 drinks a day, up to 9 a week. And that's because alcohol can temporarily increase your blood pressure. So if in excess, we don't want to continually have our blood pressure nice and high. Manage stress, so psychosocial factors. There's many different reasons for this. There's behavioral impacts, what stress causes you to do, but it's also when you're stressed or feeling anxious or depressed or nervous, your blood pressure is higher. So if you're in that chronic state, you'll have chronically high blood pressure at that point. Okay, so diabetes. If you're already diagnosed pre-diabetic, we actually are a little bit more strict with your blood pressure targets. We want those to be a lot lower, no higher than 130/80 as our cutoff value. Reason for this, we'll talk about diabetes a little bit more, but it acts the same in causing that damage with your arteries. So we also want to control all those other risk factors. Take your medication, and again, keeping a blood pressure log, quitting smoking, that blood pressure log will actually help you to know where your blood pressure is at, what's normal for you, what those trends are, because otherwise we have no way of monitoring that. All right. Okay, so we're moving on to cholesterol. So cholesterol is a waxy substance, it's a fat-like substance, it floats around through our bloodstream. It's actually beneficial. Up to 80 to 85% of it's manufactured by our body, so it's required for hormone function, for breaking down fats in food, for cell cushioning and function and membranes. So there's actually a role it plays, but too much of a good thing is not a good thing. Okay, so with cholesterol, we talk about a few different numbers as well. So LDL, I'm sure everyone's heard of bad cholesterol, bad and good. So LDL is what we call our lousy cholesterol. Our little trick for remembering this, L for lousy, and L we want it to be low. Okay, HDL is our healthy cholesterol or our good cholesterol. So we want that one to be higher. Okay, so what LDL is our low density lipoprotein. So it's a type of cholesterol that does form those plaques. So once there's damage to the artery or we have excess of it, it has nowhere to go. So it's starting to stick along those artery walls, form that plaque, narrow those arteries, which is leading to that coronary artery disease, right? The role of HDL is to act like a little bit of a scavenger. So the more HDL we have, the better it is. So it's going around picking up the cholesterol to bring it to the liver to be excreted by the body and processed before it's stuck to the balls. So the more HDL we have, the better, okay? So there's different balances with those. Our triglycerides, these are a type of fat found in our bloodstream. Our target is to be below 1.7. Triglycerides love sugary, high carbohydrate, simple carbohydrate, alcohols, sugars, sweets and treats, pastries, that sort of thing. Okay, so what triglycerides are, it's a molecule of fat and glucose, and it's floating around, our body's main source of energy. But if we're eating excess of that, and we don't require that energy, it's going to store it in our fat cells for later. So in between meals, this is a great tool so that when we're hungry, we don't have enough energy to get through, it's going to start using those triglycerides as energy and pull them out of our fat cells. But if we're chronically doing that, we have too much excess of those calories, we're going to have an excess amount of triglycerides. They're also going to attach to those walls, just like that LDL, to form those plaques. Okay? So the best thing that we can do with our cholesterol, I'm going to sound like a broken record on all of these, is to increase our fruits and vegetables. Okay, so having high fiber foods, whole grains, fruits and vegetables, the fiber acts as a binding substance. It doesn't allow the cholesterol to be as rapidly absorbed into your bloodstream, so it's giving it time to be digested, worked through, and then being processed through the body before it's absorbed and to form this plaque. Eating less of the trans and saturated fats, so things that are typically animal products have higher saturated fats or higher fat meats. Dairy products, those sorts of things have elevated cholesterol or saturated fat, which converts to cholesterol in our bloodstream. So that will help lower your LDL overall. Your HDL loves exercise. So this healthy cholesterol loves exercise. Aerobic exercise, so again, that minimum 150 minutes a week. That moderate intensity exercise. It also really likes resistance and strength training exercise. So if you can work your muscles a little bit more, you're going to have a little bit more metabolically active tissue. It's going to burn this a little bit more and increase your HDL, which is going to help remove that LDL or the other cholesterol within your bloodstream. But HDL also loves fats. So we want to remove a little bit of the fats for our LDL. HDL, we want to give it the fats, but we want to work on, focus on the healthy fats. So things like our monounsaturated fatty acids, like olive oils, nuts and seeds, walnuts, avocados, those sorts of fats are really rich and help our HDL stay nice and positive. As women, HDL is also impacted dramatically by our hormones. So at menopause, this is one of the key factors that are linked to our increased risk. So for both men and women, LDL increases as we get older. But for women, our HDL starts to decrease. So our protective effect typically comes from having that elevated HDL as we're going through our life with our hormones. As our estrogen levels drop, so does our HDL. So that's why our risk dramatically increases. And our triglycerides, again, it's those sugary things, those simple refined carbohydrates. So focusing again more on those in moderation and higher in whole wheats and whole grains. Okay, the last one that we're going to go through here is our diabetes. So diabetes is a chronic condition. There's three main types. Type 1 is considered an autoimmune disease. It's typically in childhood when you're diagnosed with it. It's that your body cannot produce insulin. So typically people with type 1 diabetes are on an insulin pump or require insulin injections as their main source of treatment. Type 2 diabetes, it can be diagnosed at any point in your lifespan. Typically, we see it more in the middle ages after we're a little bit older and our risk starts to increase as well. And this is that your body cannot produce sufficient insulin or it's not responding to the insulin in your body any longer to actually manage. So the reason why insulin is so important is that when we have high blood sugar in our bloodstream, so the glucose is floating around, that causes damage it causes damage just as it did with the blood pressure. So it's starting to cause that scarring or the damage to the artery walls, which is leaving a nice sticky substance for that cholesterol, triglycerides, those fatty deposits to stick to, and causing and forming that narrowing and stiffening of the arteries. The other reason it starts to affect our organs. So too much sugar is like a poison on some of our organs, so we start to see damage with eyes, our kidneys, other conditions as well. Okay, so insulin plays that hormone replacing role with it. So diabetes risk for your risk if you have diabetes for cardiovascular disease is doubled. Okay, so this is because of the significant impact it's going to have on your vessel walls. And the third type is our gestational diabetes. So this one again is unique to women. We talked about this a little bit when we talked initially about the sex hormones. If we've had gestational diabetes, it's typically an onset. Maybe it's not been diagnosed prior to pregnancy, but it's that your body and the hormone levels your insulin is not sufficient and you're not responding to the insulin in your body, or it's not capable of producing enough to control the sugar. So similar mechanisms to a type 2, but it's at pregnancy and it's due to hormonal conditions. Oftentimes, after delivery, your blood sugar will normalize over time. However, that does now put you at a higher risk of developing cardiovascular disease later on in life. Okay, so we start to see those women, typically at a younger age, develop type 2 diabetes if you've had that at pregnancy. Okay, so what can we do for diabetes? Again, everybody, eat more fruits and vegetables, exercise 150 minutes a week, maintaining that healthy weight, right? So oftentimes a healthy weight for everyone is a little bit different, but if we're doing those things, if we're eating the right foods, if we're exercising the right way, we're managing it, it's those actions that are going to help us to maintain where we want to be and control a lot of these risk factors within it. With diabetes, we again, because of that damage to your arterial walls, we really want to be monitoring your cholesterol values as well. So we use higher risk targets for those. We use higher risk targets for your blood pressure as well, just because there's increased risk of damage already. So we don't need any excess cholesterol in there to start clogging that up as well. Okay, so the last thing I'm going to go through here is our testing guidelines. So for cholesterol, don't worry too much about these targets. These are for high-risk individuals or individuals that have cardiovascular disease already. Typically, this is just sort of a guideline for you that you know that if you can go to your healthcare provider to find out when we require testing, when you should have things checked, or how you're at. So if your cholesterol is controlled and you have a condition or you're high risk, typically we're repeating your lipid profile about every 6 months, so twice a year. If your physician's worried about it progressing or moving in a different way, it's every 6 months. If you're uncontrolled, we're checking that every 3 months. Okay, so that's just to see if we can make those modifications. So lifestyle changes that we implement might take us up to 2 months before we actually see changes in our blood work. Okay, so we're giving you 3 months to check this, but we're trying to look at and monitor that quite frequently. We're also looking at any new medications. You also want to be checking that more frequently as well. Okay, so for your blood pressure, again, because we don't know where our blood pressure sits, we recommend that everyone does check it fairly frequently. If you are controlled and have always been controlled, one formal check a year is pretty sufficient. But if you're walking around, if you're at the pharmacy, if you're someplace, if you have it at home, recommend checking it every once in a while just to see where you're at. We also have a blood pressure station today. So we have 2 nursing students over on the track. Once you're out there walking around, they will have you do a resting blood pressure and they're going to check that. So if you are interested in getting your blood pressure checked today, we do have a station where you can do that. So feel free. Diabetes, so with our blood sugar, if you're controlled, if you are non-diabetic, every 3 years, every 2-3 years with your annual physical, that sort of thing can be checked. Your hemoglobin A1C, so we're looking at the average of your blood sugar over a 3-month period. If you have a pre-diabetic reading, if you have diabetes, typically we're going to be checking that every 3 months. Okay, so that's just to give us a nice average to see where we're at. Similar to the cholesterol, we want to make those lifestyle changes, impact that before it becomes a problem. So we're checking those every 3 months. If you're controlled, you're starting a new medication, you have diabetes newly diagnosed, might continue with those 3 months, moving to 6 months until later you're going to be moved on to the once a year. Okay, so those are just sort of some guidelines if you're wondering where you're sitting, where you're at. If you don't know your numbers, what can you ask your physician for? How frequently have you had things checked? This can be a little bit of a guideline for you. And then as Carrie mentioned, so we're just putting a little plug in here, we have our 3rd annual Canadian Women's Heart Health Summit here in Ottawa on April 2nd and 3rd. Registration is open, so we hope to see a lot of you there. And I have no idea what time it is, but I'll open it for questions if we do have time. If not, yeah? Okay. Hi.
It may seem an obvious answer, but I'm just wondering if eating sweets elevates your sugar level. Because, for example, fruit has a lot of sugar in it. But if you had a sweet tooth and ate a lot of sugar, cakes, candies, whatever, does that elevate your sugar level, which is what you're talking about?
With diabetes?
Well,
or
no,
with just elevated in general?
Yeah.
Yeah, so simple refined carbohydrates can affect your blood sugar levels. It's not the only factor. What you're looking at, so with fruit, if you're comparing fruit to a donut, there's a little bit of a difference, right? So the fruit actually has some fiber in it, which lowers the amount of free floating sugar that's going to be in your body. So the more fiber you have, the slower the absorption of the sugar into your bloodstream. So you're able to process it, and sugar, it's forming those triglycerides, you're burning it off. So you're able to utilize it before it's increases it. But if you're eating a lot of white breads, white pastas, white rice, white flour sources, sugars, alcohol, those sorts of things, which are free floating sugars that are just in the food, that will elevate your blood sugar at that point. Yeah.
Okay, so it's partly how the body's processing it.
Yeah.
So if I had a bag of jujubes and whole wheat bread at the same time, it might be okay. Just thought.
Yeah.
Sneaky.
Hi.
I just wondered, can we have access to these slides?
I don't see.
Email them maybe to participants?
Yeah, I'm looking for Lisa. I don't know where, but do we have contact, or is there?
Maybe what we can do is you can leave, if you're interested, you can leave your email address at the front desk, check-in desk, and we can email these to you.
I was madly trying to
Oh.
do this, and then I'm not really listening. So
Yeah, absolutely. And there's a lot of this information. I'm not sure if it's on yourheart.ca. Yes, so the infographics, there's some of those there. On our prevention and wellness site, you'll also find under heart health education, there's a lot of extra information there too. But absolutely, if you want to leave your email address, I have no problem with that. Yeah. Hi.
And some of the machines that you find in the drugstore, they have 140 over 90 as being the, if you're above that, as being excessive. Your slides had 130 over 80.
So 135 over 85 is now the new diagnostic criteria for blood pressure. 140 over 90 was the guidelines for, I think it changed in 2018. Somewhere around that, 2018, I believe, is the new, so it actually became a little bit more strict. And especially for women, blood pressure is a more significant risk factor as well. So we already have narrower arteries and vessels, so that if we have a little bit more of that restriction or higher blood pressure, it's significant. So they've actually just decreased the target. Yeah. Hi.
Recently, the same day, for example, when I came here, the doctor reads my blood pressure, then 10 minutes later he reads again, and the number changes. And myself, 2 days ago, I arrived here, it was very high. At night I went for a walk, about an hour. I come back, it was almost never seen so low.
Yeah, well, that's a great point. So with blood pressure, your blood pressure does fluctuate day to day and depending on what you're doing. So often if you think of the first time when you're meeting with your physician, let's say, or you're at your doctor's office, you might be feeling a little anxious or nervous. You might have just fought for parking here. You're trying to run in. Anything like that can actually affect your blood pressure. Even if you have to use the washroom, that sort of stuff can actually increase your blood pressure. So doing it the first time, that's often probably why he's checking it or she's checking it later, is just to see if it's, now that you're resting, we're talking about that relaxing. So when you take your blood pressure, we do recommend that you sit silently, feet on the floor for about 5 minutes, rested, put the cuff on before you're even pressing start. So if you're in there, they're talking to you, the blood pressure's on, it might naturally be higher. You could also have nervousness and that white coat syndrome. With exercise is almost as effective as taking a blood, like if you could take an aspirin for blood pressure, which you can't, or like a Tylenol for blood pressure, exercise can drop it immediately like that afterwards. Okay, so it is really effective.
The overall reading should be, because we have a very low reading, say, okay, now we don't have that.
Right.
What's the conclusion that they should take?
So you should take a blood pressure log, recording the time of day that you're taking it, some of the activities that you did. So if you find your lowest one, you might say, took this at 6 p.m. after a 30-minute walk. I had my highest reading ever at 9 a.m. in the doctor's office, that sort of thing. So it'll help you to interpret the numbers and some of the behaviors that go with it. And then it's up to your physician too, to work with them to see and monitor that.
This will be our last question, but Natalie's going to be around all day. If you grab her, she'll be happy to answer the other questions you might have.
My question is about blood pressure too. What's considered a dangerous blood pressure where you should really think about going to the hospital when it's at a certain level?
Right. So a hypertensive emergency, I believe, is systolic of 180 with a I'm looking at TICE too to make sure, diastolic over 110. Is that correct? Hypertension emergency, systolic of 180 and diastolic of 110?
It's not just the blood pressure; it's the blood pressure and symptoms.
Okay.
So if the person is having symptoms of stroke and some mental status changes, those are the high blood pressure plus the symptoms will make a hypertension emergency.
Okay.
Many people will walk into the office with extremely high blood pressures and be feeling just fine, and that's not an emergency.
Sure. Okay. Yeah. So we typically in our prevention programs we follow those cutoff numbers, but we also have to triage for symptoms. Yeah.
Thanks
Okay.
very much, Natalie. Fantastic presentation. Yourheart.ca. You can look for tools and resources. You'll find all those infographics on the website for more information.